Okay, hello everyone. Thank you so much for having me. I'm going to find my slide advancer here. So it's really an honor to be here, and among this great group of colleagues, I have again learned something new every time I listen to these individuals, and hopefully you're gaining a sense of the mission of the importance of the integration of early palliative care if you're not as familiar with it. For those of you who are MGH individuals, for me it feels a little bit like I'm preaching to the choir, because they kind of undersold the importance of that study. There really probably isn't a palliative care practitioner in the world who hasn't cited that 2010 study about how palliative care not only improved quality of life and lowered depression, but increased life. People live longer. So that was an extremely influential and groundbreaking study. So let's see while I figure out my buttons here. I think I got it. Okay, so I have some quick main points. I'm giving an oncology social work perspective, but the values of oncology social work are really shared among probably everyone here. We all buy into and support psychosocial oncology. So I'm using the oncology social work example, but it really is applicable across professions. And so I'm going to describe that a little bit and then go into why oncology social work and everyone else really should advocate for early integration of palliative care with those affected by cancer and serious mental illness, and then go into a little bit about how to do it, or at least how to start it. So what is oncology social work? According to the Association of Oncology Social Work, it's the practice that provides psychosocial services to cancer patients, their families, and caregivers as part of the oncology healthcare team. We conduct research and connect patients and families with essential community, state, national, and international resources, as well as end-of-life care. And so what you see here is a list of the functions of the clinical practice of social work popping up, from psychosocial assessments to determine survivor and family strengths and needs relative to coping effectively with cancer diagnosis, treatment, and follow-up. Interdisciplinary care planning with survivor and family input based on mutual goals. We do a range of therapeutic and other interventions, including supportive counseling, group work, and education to address issues in each phase of illness. We do pre-admission, transfer, and discharge planning, case management services, as well as direct assistance to meet financial, transportation, lodging, and other needs, and proactive provision of services to at-risk populations, including assistance with negotiating barriers to cancer information, screening, treatment, and resources within the institution and the community. You see collaboration, advocacy, the removal of barriers, and addressing gaps. And finally, research. We do participate in research, and we are developing our own research knowledge base as well, looking at the impact of cancer, refining interventions, as well as evaluating practice outcomes. So going to a wider stance from oncology to social work values in general, this kind of explains why social workers are so weird in a lot of ways. Although, obviously you see things that are shared among multiple professional core values. You see service and competence and integrity. We place a huge importance on the value of human relationships and the dignity and the worth of the person. And of course, social justice. And I just want to read that one ethical principle that we have for you. Social workers pursue social change, particularly with and on behalf of vulnerable and oppressed individuals and groups of people. Social workers' social change efforts are focused primarily on issues of poverty, unemployment, discrimination, and other forms of social injustice. These activities seek to promote sensitivity to and knowledge about oppression and cultural and ethnic diversity. Social workers strive to ensure access to needed information, services and resources, equality of opportunity, and meaningful participation in decision-making for all. That one's particularly relevant to the topic that we have today, and that's why I wanted to share that with you. And of course, when you think of social workers, think about PI. Why? Because we focus on the person in the environment. That's like social work 101, that when you first go to school, you learn about the person in the environment. And because of that, we focus a lot of our assessments and our interventions on the social determinants of health. Again, super relevant to this population in particular, but we know the studies that are out there, and there are many, say that social determinants of health impact health outcomes anywhere from 50 to something like 70% of health outcomes are determined not by medical interventions, psychosocial or psychological interventions, but by social determinants and social interventions. So these are super important for us. So moving into why should we advocate then for early integration of palliative care? We've kind of gone through the social work values and values that I believe are probably shared by many of the other professions as well. The main reason is because palliative care is patient-centered care. And patient-centered cancer care is care that is respectful of and responsive to individual patient preferences, needs, and values, and ensures that patient values guide all clinical decisions. And it's not something that they say and then just don't do. Palliative care really, really does it. They set the example and a very high bar in making this happen. They consider the patient as a whole person, beyond their disease, from the time of diagnosis through the balance of their life. And it's respectful of the patient's preferences, needs, and values related to the involvement of their family and friends in their care. And it empowers the patient to participate in their care in a way that is consistent with their preferences, needs, and values. And finally, it requires that multiple levels of cancer care delivery are designed to accommodate the needs of patients and caregivers, acknowledging the care delivery system must support providers to function effectively. This one in particular, multiple levels of care. This is specifically about breaking down the barriers which this collaborative has tried to do beyond just doing care in institutions and moving out into the community and collaborating between the two and then supporting the providers to do that. That's what this last one's about and why it's so important. And that is self-actualized patient-centered care if there ever was one. So palliative care seeks to attain these lofty goals through the use of an interprofessional team. And there's no one profession that can accomplish all the needs that our patients have. And with palliative care, they really are committed to the interprofessional team approach. Now, there are many, many, many team members, and like I said, the importance of a team goes way beyond just individual clinical teams and moves into the community care as well. But with palliative care, the core primary professions that you most often see, of course, are the chaplains, the physicians, the social workers, even psychologists, registered nurses, and nurse practitioners. And then you see, again, patient, caregivers, family, right there at the center. And that's a common theme among all palliative care teams. So we've kind of gone through the core value of palliative care and its value on patient-centered care. And I highlighted some social work values. And hopefully you've seen that there's really a lot of overlap between the two. And why it's so easy for social workers in general, not just oncology social workers, but social workers in general, to fully support and buy into this concept. And Dame Cicely Saunders, you know, we like to argue, she's kind of a walking interprofessional team. She was the founder of the hospice movement in England. And we like to argue about what she was first. I think she was a social worker first, personally. Okay. And then she became a nurse. And then she went and got education to become a physician so that she could do hospice. But she integrated the values of all of those professions to create what was the first kind of version of palliative care that we had that was formal. So that was just, that's why it makes so much sense, particularly for social work. But also, I would ask you again to examine your own, the healthcare professionals in the room. If you haven't thought about those core values in a while, go back and read them. Some of us have to do that every once in a while. And just look to see where it aligns and look at the other main values and mission of palliative care in general, and look to see where those things align and start to think of ways that you can integrate that into your own practice. So, because of that, here's my statement: social workers must, absolutely must, advocate for early integration of palliative care with cancer care. And I was going to cite that study, not actually realizing that it's already been cited a couple times today. And there are multiple other studies out there that support those findings. So it's very, very important. So how do social workers and everyone else in the room start to think about ways to integrate palliative care early? Well, the social worker role in palliative care is doing some of the things that have kind of already been brought up here today. Planting the seeds about a time when a cure might no longer be attainable and the treatment focus may need to shift, that cultivating prognostic awareness, assessing or assisting patients in expressing their hopes and goals, as she said, Dr. Jackson, this is everyone's responsibility. These are some things that we do, but it's really, really everyone's responsibility. Supporting patients and families through the transitions in physical and psychosocial abilities, navigating differing goals of care between patients and caregivers, as we have heard highlighted in some of these patient stories today, counseling patients about advanced directives, and a huge and super important one for social workers in particular is bridging communication and education needs between the patients, families, and all healthcare providers and teams, again, across barriers, across institutions and settings and into communities. And for oncology social workers and their work with those living with serious mental illness, it's really about going back and applying those core social work values and standards, which really do mandate the mission of this collaborative, which is the prevention of premature cancer mortality and the improvement of quality of life of individuals affected by mental illness and cancer. Going back to dignity and worth of the person and social justice, and thinking of ways to apply those concepts with this particular group of patients who need us. And it's even more about super extra comprehensive assessment. We all try to do comprehensive assessment, but we have to do it more in depth and in different ways, as you heard highlighted today already by Amy in some of the stuff that she did. And it's not just assessing the patient, but assessing caregivers, community supports, community clinicians, and patients, looking at the strengths and barriers with each, and thinking outside of the box for solutions to those barriers, and then really challenging the healthcare team and the system to do the same, to think outside of the box, to solve problems. And this is what today is all about. You know, what this actually looks like in practice, you heard already in these cases, but also the rest of the sessions throughout the day are going to be grappling with these things, these issues, and kind of what that looks like. And then, of course, with community clinicians, include palliative care, look for us, we're out there. And if you imagine, like what you saw today with the two cases, you saw a wonderful medical and psychosocial skill applied to these cases, and these patients had excellent care. And they used a lot of the generalist approaches that palliative care supports in their approach to the care of the patients. What might it have been like for these teams that were facing these challenges had they had that extra layer of support of either a hospital-based or a community-based palliative care team that could have been intervening as well and supporting the family? It could have potentially been a little bit less stressful. There could have been a little bit less suffering a little bit earlier on. So I just challenge us all to continue to think about incorporating palliative care. So now to get to it. Has everyone here heard of this? The Clinical Practice Guidelines and Quality Palliative Care put out by the National Consensus Project? If not, this is something you want to check out. You could go to the website there and download it for free. You can read it online for free, or you can actually purchase a copy. It puts out a list of guidelines that they update quite regularly. The 4th edition just came out. And they aim at improving care and the safety of patients and families. It defines structures and processes of care and sets expectations for providers. It guides clinical decision-making and promotes standardization. And it creates a foundation for accountability. These guidelines provide essential elements for standards, policies, and best practices. And it's not just, it doesn't have to be just for palliative care teams. Like, you can read through this document as a healthcare team, an oncology team, or otherwise, and think about ways that you might incorporate some of its principles in your own practice. Some of the key concepts, of course, are patient and family-centered approach to care. It's inclusive of all people living with serious illness, regardless of setting, diagnosis, age, or prognosis, as Dr. Jackson said. And it's a responsibility, and this document really promotes that. It's the responsibility of all clinicians and disciplines caring for people living with serious illness. So their premise is it's everyone's responsibility. And to use that document and consume what's in there to apply into your own practice. Some of the domains that are included, you can see here, it starts with structures and processes of care, which really highlight the roles and the structure of the team itself and the education requirements of a palliative care team, as well as what an interdisciplinary assessment might look like for the team. Then it goes into that what is the whole person? All the aspects of care that make up the whole person, from the physical, the psychological and psychiatric, the social, the spiritual, religious, and existential, and the cultural, and of course, ethical and legal aspects of care. And it does touch on care of the patient nearing the end of life, because there does need to be some specialized knowledge in that area. So you can look and see the whole person here, and there's nothing missing there. And when you go through it, this is a several-page document that lists, line by line, specific recommendations for care in each of those areas. I just pulled one for you as an example today. I pulled the psychological and psychiatric aspects of care, and this is the description. Interdisciplinary team addresses the psychological and psychiatric aspects of care in the context of serious illness. They conduct a comprehensive, developmentally and culturally sensitive mental status screenings. The social worker facilitates mental health assessment and treatment in all care settings, and then communicates to the patient and the family the implications of psychological and psychiatric aspects of care. So that's kind of like the description of what it is. Then here's just one guideline. There are many within this domain of psychological and psychiatric aspects of care. The interdisciplinary team includes professions who have received training in the potential psychological and psychiatric impact of illness, including potential distressing behavior changes on both patients and families as they relate to psychological well-being. The team has or has access to staff with training to recognize and treat common psychological issues, including anxiety, depression, delirium, hopelessness, post-traumatic stress disorder, and substance use disorder and withdrawal symptoms, and more complex psychiatric issues, suicidal ideation, serious and persistent mental illness, as well as personality disorders. This is all within that one guideline. So this is a wonderful resource for everyone in this room, even patients and families. Go and look, okay, this is the kind of care I want. I'm going to go and ask my doctors to help me get this type of care from now on, because we talked about kind of how do we get palliative care earlier with patients and families, and we have a lot of data that also says the number one barrier to people getting palliative care is not the people, it's not patients and families, it's providers. And it's because of our use of language and the way we describe it, as Dr. Jackson has already highlighted. There's a huge difference in, well, there's nothing else we can do for you, it's time to call in hospice. How would you hear that versus, it might be time, because I'm really disappointed that we haven't been able to cure your cancer with the treatments that we've offered. It might be time to talk about shifting the focus of your care from really aggressive curative or life-prolonging to really aggressive symptom control and aggressive support in a setting that makes you the most comfortable. And that kind of care is either palliative care or hospice. And there's a huge difference. And when patients and families hear it in that way, they're able to receive it and they're able to do it because it doesn't communicate abandonment. So because of that, I'm kind of closing with, there's one more thing after this, but integration of palliative care with curative and life-prolonging care is a responsibility for all of us who are caring for these patients with serious cancer and serious mental illness. And for more information specifically around social work, palliative care social work, and oncology social work, there's some great Oxford handbooks that are out there for you social workers who want to have more information. This is a wonderful, wonderful resource. And any directors in the room, make sure you buy at least one copy of both of these books for your cancer center or your palliative care team, because they are just truly wonderful resources. Now, the other thing that was mentioned in the intro, and also Oxford puts out palliative and oncology handbooks for nurses, physicians, as well. So there's a great list of, a great reading material for practitioners. The other thing that I do at the University of Louisville is something called ICOPE, the Interdisciplinary Curriculum in Oncology Palliative Education. This was an NCI R25 that was funded several years ago, where we recreated a mandatory interprofessional oncology palliative curriculum for all learners in the School of Medicine, Nursing, Social Work, and chaplain residents in town. And it is and remains to this day truly mandatory, even though we have the funding is over because it was several years ago. But to date, we have close to 3,000 learners who have gone through this ICOPE curriculum, learned how to learn together around these concepts of palliative oncology, who've now gone into the world and have gone into residency all over the world, or all over the country in particular, and have, in an earlier time in their career, bought into the interprofessional palliative care approach, particularly with cancer care. So there are some things online on the website that you can do. You can go and do some of those online modules if you want to learn more about the integration of palliative care early in oncology care. We have a few case-based approach modules that are in there. And then if there are any teams in the room who are wanting to get more information about how to create interprofessional palliative oncology learning experiences in your own clinical settings or for your learners, that was the other study that's currently ongoing that we're doing. And I have information at the AOSW table out there about both ICOPE and IPEX, the new one, where we are recruiting right now faculty teams who want to create their own interprofessional palliative oncology learning experiences. So that's it. Thank you very much.